Marks, President of the International Union Against Tuberculosis and Lung Disease. Marks is Professor of Respiratory Medicine at the University of New South Wales. As a respiratory physician, epidemiologist, researcher, and public health physician, Professor Marks has worked in respiratory medicine for almost 4 decades. His main research interests are in chronic respiratory diseases like asthma, then tuberculosis control, and adverse health effects of exposure to air pollution. Now, just a few housekeeping announcements before I hand over the mic to our esteemed speaker. Audience, please keep yourself muted and your videos turned off throughout the session. You can type in your comments and questions in the chat box, even as Professor is presenting, and we will take as many questions as time permits after the presentation. Over to you, Professor.
Thank you very much, Shabashkalu. Thank you very much for inviting me to speak today and for those kind words. It's a great pleasure to be here, and I always enjoy talking about asthma because, as you said, I've been working in the field of asthma for many years, and it is still a much under-recognized major global health problem. I'll just say a few words now, but I'd be very happy to answer any questions that you might have about this. Much of what I'm presenting to you today actually comes from this report. I've been part of an organization called the Global Asthma Network, which was actually formed initially between the Union and a group of researchers who did the international study of asthma and allergies in children. And it's led by Ines Asher, who is a colleague, a professor of child health in New Zealand at Auckland. And she has been the leader of a lot of this work and has worked and is the leader of the Global Asthma Network. So I want to pay acknowledge her major contribution to this. The Global Asthma Report is available on the net and has been supported by the Union throughout its existence. We'll have another version of this coming out next year. These data are data from the Global Asthma Report. In fact, initially from the study that I mentioned before, the international study of, I'll put my my pen thing on, hang on, so that you can see my laser point. The international study of asthma and allergies in children. And this shows the prevalence, the number of people, the proportion of the population that have asthma amongst children, in this case, aged 13 to 14-year-olds. So adolescent children, how many of them have asthma? And the highest burden places are these places that are in are shown here in the red stars, and the next highest burden places are those that are the purple diamonds. And you can see there's lots of them in the Asia Pacific region. A lot of places have a high burden of asthma in our region, and in fact in many parts of the world there are many places where, you know, more than 20% of people having asthma means that more than 1 in 5 children in this age group have symptoms of asthma. So it's a very common problem in children and in adults. It's the most common persistent or chronic respiratory, it's the most common chronic illness in children. It's the most common illness that occurs over a long period of time in children. We've measured, we tend to measure the burden of disease using a currency, if you like, during measures, using measures that are comparable. And one of them is the number of people who have the condition. And this shows us that we have about 4,000. The global burden of asthma, 4 million, in fact, people have asthma globally. 4 million, this is, yeah, it should be 4 million people have asthma globally, and it isn't really changing over time. On the right-hand side is the number of deaths. These are the number of deaths globally. About 12 per 100. I'm actually not sure what the units are, come to think of it, but these are the number of deaths, and they've been declining gradually, but not fast enough, and there are still very many deaths globally. This is another measure which measures both the number of people who have the condition, the number of people who die from the condition prematurely, and the number of people who are disabled by the condition, the number of people who have symptoms or disability due to the condition. And we call this disability adjusted life years. And it also remains very high globally. So the global burden of asthma is high and is only slightly decreasing over time. One of the key features of asthma is that it affects people of all ages. There are some diseases that are affecting mainly older people, many diseases that affect mainly older people, and other diseases which are common, particularly in children, like diarrheal diseases and so on. But asthma is in fact a disease that affects people of all ages. And you can see here that the rates are actually the highest in older and younger people, and lowest in the sort of middle years of life. The other thing about asthma is that it affects people in all parts of the world, in high-income countries and in low-income countries. So whichever, it's not a disease that is particular for a problem of the poor or of the rich. But what is a particular problem of the poor is deaths from asthma. So if you have asthma and you live in a high-income country, your risk of dying is very low. So most people who have asthma in high-income countries do not die from the disease. Whereas if you live in a low-income country, low or low middle-income country, your risk of dying if you have asthma is much greater. And in fact, it's said that about half of all deaths in the world due to asthma are occurring in India. Half of all of the deaths in the world due to asthma occur in India. And why is this the case? Well, I think it's probably due to a lack of access to effective treatment. The most effective treatment for asthma is a treatment known as inhaled corticosteroids. This is a treatment that's been used for asthma for over 50 years. It's not new. It's been around for over 50 years. It's very effective, but it is not readily available in many parts of the world. The second thing is the lack of access to acute care for attacks. When people get bad attacks of asthma, they're at risk of dying of those attacks, and they need acute hospital care that is effective for managing those attacks. And that in some countries that is not readily available. And finally, it may be that there are more exposure to some of the things in the environment that trigger or make worse asthma. And the most obvious of those is air pollution. So in countries where there are high levels of outdoor air pollution, smoke, traffic-related air pollution, industrial air pollution, it's quite likely that people with asthma will have more severe attacks and be therefore more at risk of dying. So I think these are the three major reasons why deaths from asthma are so much. So even though, sorry, I'm trying to make this go back. So even though the number of people who have asthma does not differ between high-income countries and low-income countries, the number of people who die due to asthma is much higher in low-income countries. I think it's because mainly of these three things. There are some identified important airborne triggers, not just for asthma, but now I'm talking about all disease. What this shows is the most important risk factors for the global burden of disease in general. So this is now not just talking about asthma. And you can see, in fact, overall, high blood pressure is the biggest risk factor for disease. And most of that is due to heart disease and strokes. So high blood pressure causes a lot of heart disease and strokes. But for these, I've highlighted these three, which are the respiratory, the airborne hazards, the things that you breathe in. Tobacco smoke, either by smoking directly or by exposure to secondhand smoke. Household ambient air pollution, largely due to cooking fuels and heating fuels indoors. And ambient meaning outdoor air pollution, of the sort that I was just describing. Outdoor particulate air pollution from agricultural burning, from traffic, from industry. And you can see that while respiratory disease, which is shown here in this light blue color, is one of the consequences of these airborne exposures. In fact, there are a number of other consequences of these airborne exposures, including heart disease and strokes. This color here is heart disease and strokes, here and here. So they're important consequences of exposure to tobacco smoke, household air pollution, and ambient air pollution. But also cancer, that's this dark blue. Of course, we know that tobacco smoke is associated with cancer, but so is particulate air pollution, shown here. And this is infections, pneumonia, basically, largely pneumonia. So household exposure to solid fuel combustion from stoves associated with childhood pneumonia, secondhand tobacco smoke associated with pneumonia, and outdoor air pollution as well. So these airborne threats to health are very important risk factors for disease, not just respiratory disease, but more generally. Coming back to asthma, I wanted just to come back to treatment for asthma. I mentioned a couple of slides ago that lack of access to inhaled steroids is a very important factor in the high morbidity and mortality, the high number of attacks of asthma and deaths due to asthma in low and middle income countries. And there are a lot of issues about access to medicine. A key part of managing asthma and stopping people from having symptoms and stopping people from dying from asthma is getting access to effective treatments. The right medicine should be available, prescribed or recommended by the treating doctor, affordable to the patient. It needs to be quality assured. It needs to be good quality medicine. There's a lot of medicines available that are not good quality. Because a lot of these medicines are taken by inhalation. I think I showed you the very first slide, shows you a child taking medicine by inhalation. This one. Because a lot of medicines in asthma are taken by inhalation. Both children and adults with asthma need to know how to use these devices. It's not simply like taking a tablet or a medicine. And they need to remember to take it, and they need to actually take it. So these are the key issues for us in access to medicines for asthma, that they have the right medicine, that it's available, that it's prescribed, that it's affordable, that it's quality assured, they know how to use it, and they do use it. And I just want to acknowledge these people also from the Global Asthma Network and the Union. This is Chenyuan Chang, this is Karen Bissell, and this is Nadia Aid-Khaled, all three union people who've worked on this work in this field for many, many years. This is a study that was done by Nadia Aid-Khaled, in which she looked at the comparative costs in US dollars for treatment, for a year of treatment for a person with moderate asthma in 8 middle and low countries, compared to the monthly salary of a nurse. So this was a year of treatment and the monthly salary of a nurse. And you can see here that in many countries, the cost of treatment for asthma was near to the a month's salary. Clearly not affordable. So the point of this is that asthma treatment in many countries, this is now some time ago, and there has been some improvement, but not enough. And so there's not been enough improvement, and this major barriers to access due to affordability is a major issue. I'll just briefly talk a little bit about asthma in older adults. This is some work that I did with my colleagues Peter Gibson and Vanessa McDonald in Australia, about thinking about asthma from a multidimensional perspective. So I've talked to you about treatment. So pharmacotherapy is about access to drugs. But we need to think about the management of other problems that people have. So many people with asthma, particularly older patients, have many other conditions that complicate their asthma. Smoking-related lung disease, obesity, underweight. They sometimes have heartburn or indigestion. They have a whole lot of other problems that need to be dealt with along with their asthma. We need to modify risk factors for patients, particularly things like smoking, things like diet, exposure to other trigger factors. And we need to train patients. We need to teach patients how to look after their asthma effectively. And so there's a whole package that's involved in delivering multidimensional effective care for patients with asthma. And we wrote about this many years ago, and it's now coming to fruition. Perhaps I'll skip that one. So I'll just say this is my last slide really, just to say that asthma remains a major problem globally. There is, I believe, a substantial avoidable, and this is important, there's a lot of avoidable suffering and death due to asthma, which we need to address. I would have to say that most of the progress we've made with asthma, particularly for people with mild or moderate asthma, is not about new drugs or new tests, but about new ways of using the drugs and the tests that we have available. So I haven't described all these details, but this is some specific new ways in which we've learned to use the drugs that we already have that are much more effective. These are all old treatments that are being used in different ways for managing asthma more effectively. Our big things to do, as I've alluded to several times, is about getting better access to medicine, particularly their distribution, reducing the cost, and getting them delivered to patients in a way in which they can use most easily. And there are some ways in which we can improve the selection of drugs for patients by getting better predictors, better tests that help us to use better predictors of how we manage asthma. So I'll finish at that point, and I'm happy to answer some questions. I see there is some things being put in the chat, so I'll hand back to you, to Jabashkalu, Luka, or Tara, and I can, Soba.
Yes.
I'll hand back to you, or would you like me to go through the chat? I'm in your hands.
No, thank you very much. Thank you, Professor. And if there are any direct questions sent to you by direct chat, you'll have to take them up. But we have many questions otherwise also, and we'd like to take up as many questions as possible. And it will be great, Guy Marks, if you could just leave, if it's just possible to leave your email address in the chat box. If we have any doubts later on to clarify, we'll always knock at your door, you know. So
yeah, that's no problem. There you go.
Yes, thank you. Thank you. And I just wanted to say that the theme for this year's World Asthma Day is uncovering asthma misconceptions. And we also have a question to that effect from Dr. from Health Digest from Myanmar. So what are some of these myths that need to be uncovered, and what are the key messages which should be given as part of health education for people living with asthma?
So I think the key message for health education for people living with asthma is that they need to use is about asthma treatment. In fact, as I alluded to before, that inhaled steroids, that class of medicine that is sometimes called controller or preventer medicine, inhaled steroid type medicine, and it is the treatment that is effective, controls symptoms, prevents symptoms, and prevents your risk of dying due to asthma. People do need to know that you can die due to asthma. And it's not a benign, some people think of asthma as something that's benign and harmless and so on, but it's not. People die due to asthma. And the reason they die is because they haven't been taking regular inhaled steroid treatment. If you take regular treatment with inhaled steroid type medications, you're very unlikely to die due to asthma. And your symptoms are very likely to be well controlled. So that is by far the most important message to know. There are many misconceptions about asthma, and many people will tell you what causes asthma. Every one of them that people propose as a cause for asthma is a misconception, because there is no known cause for asthma. That is the bottom line. There is no clear-cut cause for asthma. So the other thing that people should know about asthma is that it's not the same in everyone. There are different, it looks different in different people. And it is in some people it seems mainly related to allergic disease. In other people, it seems to mainly happen in association with viral respiratory tract infections. And in other people, it's related to exposure to irritants like and tobacco smoke or air pollution. It's probably not caused by smoking itself. Smoking causes a whole lot of other lung diseases. It causes chronic obstructive pulmonary disease, that's an emphysema, if you like, a chronic form of lung disease, which causes breathlessness, but it does not actually cause what we recognize as asthma. So it does exposure to environmental tobacco smoke in childhood, or having a mother who smokes during pregnancy is much more likely to have a child who will have asthma-like illness, particularly during early to mid-childhood. So it definitely makes the risk of asthma in children more serious if the mother smokes during pregnancy. Somebody asks about Montelukast here. Montelukast is another form of preventive treatment. It's not very effective. It's not as good as inhaled steroids, but it works for some people, and particularly for children. So it has some beneficial effects. And if it is, for some people, it will control their asthma, but for many people, it does not. And if it doesn't, then you need to take inhaled steroids. Inhaled steroids are actually cheaper in most places than Montelukast, but Montelukast can be effective for some people.
Okay. Yes, you have other questions there also.
There's another question with low-income countries grappling with air pollution, inaccessible. The disease is getting worse all the time. So it's not really getting worse, it's just not getting better. It has a very high burden. There's a very high burden of disease. As I said, about 500,000, I didn't say, I think, about 500,000 deaths a year due to asthma in India. And it's so it's not getting worse, it's just not getting better. and it should be getting better because that burden of disease can be greatly reduced. The slide I showed that shows that the prevalence of asthma is much the same in high and low income countries, but the number of deaths is very low in high income countries and very high in low income countries. There's no reason why the number of deaths should not be the same in low income and high income countries. The main reason is about access to medicines. And the other reason may well be things like air pollution, access to medicines, access to acute care when you get worse, and probably air pollution. They're the three things that I think are important. Somebody, Aaron, is asking, is asthma a risk factor for COVID? No, it doesn't seem to be a risk factor for COVID. There's no evidence that asthma is a risk factor for COVID. And the diseases basically should be managed in their own right. So there's no reason asthma treatment doesn't increase your risk of getting COVID. Patients with asthma should be treated in the usual way.
Then there's a question from Bobby, Professor Marks, that do you see governments more likely to take stronger action on initiatives like asthma drug facility, which can guarantee same quality of affordable medicines in rich and poor nations alike?
Well, I think governments need to, what this links to is essentially the universal health coverage agenda. The universal health coverage agenda needs to include affordable, reliable, and quality assured access to medicines for common non-communicable diseases, which includes treatments for asthma. Also needs to include treatments for diabetes, treatments for high blood pressure, treatments for heart disease. These treatments are long-term treatments that are needed by patients to keep them well and to keep them alive. And a key element of the governments need to commit to universal health coverage, which includes access to medicines. And they need to, that will involve getting access to low-cost generic formulate. Nearly all of these effective medicines are available in, well, all of them, in fact, for all of the things those diseases I've just discussed, can be very effectively managed by low-cost medicines that are off patent and it can be available generically and can be produced by manufacturers in many parts of the world. The one particular thing about asthma medicines, as I mentioned, is that they're inhalers, and there are some technical issues around the quality of the device. The device needs to be engineered appropriately so that it can be deliver the aerosol appropriately to patients. And there's a little bit of issues about that with injectable drugs like insulin. But generally speaking, the issues are much the same across all of the common chronic non-communicable diseases. I think governments absolutely need to buy into this under the banner of non-communicable diseases, and sorry, under the banner of universal health coverage, UHC.
There is a question from Nurul Islam from Bangladesh, post from Bangladesh, and he wants to know that can asthma patients take the COVID-19 vaccine? Because
absolutely.
He says in Bangladesh, people with underlying conditions such as diabetes, asthma, they tend to skip vaccines fearing side effects.
They should, well, as I said, asthma patients are no more at risk of COVID than other patients, but they absolutely should take the COVID vaccine. Everybody should take the COVID vaccine. People with diabetes are at increased risk of COVID and should absolutely even more take the COVID vaccine. Nobody should not have the COVID vaccine. There are no contraindications to the COVID vaccine. Everybody should take it. And the sicker you are, the more you should take it.
Right. Because there are so many misconceptions even regarding COVID vaccine treatment guidelines. So I think that's important to.
There are no reasons not to take the COVID vaccine. And as I say, any person with an illness should have the COVID vaccine first. Should be lining up first to have the COVID vaccine.
There's another question from Bobby. I think you can see that.
Bobby, yeah, with not enough ICUs or ventilators or oxygen for COVID alone, do you see problem got people with asthma? Well, of course, yes. I mean, that is a big issue, and it happened in other countries also during the, in Europe and in North America. I think it happened during their major first wave, when patients who needed hospital, not just intensive care, but hospital care for other conditions were either denied hospital care because the intensive cares were overflowing and the hospitals were overflowing, or were, not surprisingly, fearful to go to hospital because they worried about catching COVID in hospital, which was not unreasonable. So both reasons, both factors mean that, yes, there will be many deaths, not due to COVID, due to lack of access to hospital and to intensive care and to ventilators and to oxygen because of the COVID pandemic. There's no question about that. That's an additional, so many of the excess deaths during the COVID pandemic will not be directly due to COVID itself, but due to other conditions. It's a major problem. Yeah. No question about that.
There was a similar question from Kalpana Acharya, editor-in-chief of Health TV Online Nepal also, that to what extent is COVID-19 impacting also initiatives targeted to control tuberculosis and tobacco globally, and what can be done?
That's a good question. And look, it is, of course, having a significant impact. It's interesting. Yeah, it's having a significant negative impact in that resources and attention that would normally be paid to other public health problems, such as communicable and non-communicable disease control, is now redirected towards the control of COVID. And so that has a significant impact on all management of all of these conditions and will have adverse effects. There is a small upside, and that is that the world's attention has been focused on health in a way that has never happened before in any of our lifetimes. The attention of the global community on a health problem has never been this great, and I think that there will be some spin-off from that may be that we can, as health community, take advantage of. That I think that there will be the opportunity to realize the benefits of focus on health, on public health in particular, on prevention, and on epidemiology, on public health. And so I think all of that, I think there will be that opportunity, but as yet, we haven't yet got to that point. At the moment, we're still in the bad phase where we're dealing with the shift in attention away from other public health campaigns to dealing with COVID. But I think one of the things that I think that we've learned, we are learning some important lessons, which I hope communities and governments will pay attention to. And those lessons are that, to me, I would say that governments that take public health seriously are the ones that have controlled this problem well. Governments that pretend that it doesn't exist and that they can just go on regardless, take no notice of experts or advice, are the ones that have the disasters that we've seen around the world. So I think that's a very important lesson, and I hope that the general public will take that lesson to heart in the future and elect leaders who take health issues seriously and take expert advice seriously. So that's, I think, one important lesson. The other, I think, important lesson is that countries where people recognize that we're all in this together, that the actions that I take and that one person takes affect other people. Whether I wear a mask affects not just me, but other people. Whether I go out and socialize and go about my business as usual, or I stay home, affects not just me, but other people. And that everybody, people that understand that we're all in this together and that our own actions and what we do affect other people, those countries have done better than the countries which have this sort of vigorous individualist culture, which says that only everything is about me. Nobody else matters. It's all about what's in my interests. Those countries have suffered. And maybe we'll learn that lesson as a community, as a global community, and learn that we share this world, and that what we do affects other people, and what other people do affects us, and that we need to. And this is not just in our own local community, but in fact globally. I mean, we can see that the outbreak in India now, for example, is having ripple effects throughout the world. It's not just in India. It's catastrophic in India, but it's having effects throughout the world. So you can't control COVID in just one country. You need to control it in the whole world. And that's a lesson we need to learn for other things as well.
Yeah. So very well said, Mark. And we tend to forget that where my freedom ends, somebody else's will begin. So
exactly.
So
exactly. That's another way of putting it. It's a very good way of putting it, Shobra.
Thank you very much.
Yeah.
There's a question from Sanchita Sharma about, are we on track to reduce asthma burden and deaths by 25% by 2025 in Asia Pacific? And is any country doing better or worse?
That's a good question, and I'm afraid I don't know the answer. I think it's very difficult to track this condition. It's not a notifiable disease. There are not good data on exactly what is happening with this condition. We have some data on hospitalizations and deaths, but it's not very strong. It's a lot of it estimated. So the quality of information is poor. And one of the things that the Global Asthma Network that I alluded to before, led by Ines Asher, has been trying to do is to improve the quality of information that we have about asthma, about the burden of the disease. So I think there is a decline in asthma burden generally, but whether we'll achieve 25% reduction by 2025, I suspect not, but I think we won't know for certain. It's a very good question.
So thank you very much. I think we've already taken more of your time than you had promised.
It's my pleasure to speak with you, and I'm very grateful to you for paying this attention to asthma today. It is a very significant disease, as I said. There's a lot of avoidable suffering and death due to this condition, and we need to do what we can to mitigate it.
So with this, we come to the close of today's session, and my sincere thanks to Professor Guy Marks and to the audience for enriching the session with their participation and questions and comments and the wonderful answers we got from our speaker. So bye for now. Stay safe, stay healthy, and stay connected.
Thank you very much.
Thank you very much.
Thank you. Bye.
Bye. Bye, everyone. See you.
Thank you. Bye.
Bye.
Thank
Bye.
you. Thank you so much.